Good afternoon and welcome back everyone to the Indiana Division of Mental Health and Addiction INARMS Symposium. We are just about to kick off session 4. Before we do so, special thanks to Anthem, Blue Cross and Blue Shield for being a stakeholder sponsor. At Anthem Blue Cross and Blue Shield, we work to ensure our members get healthy and stay healthy. We're passionately committed to providing access to high quality care to members, delivering value to our providers, and helping improve the health of communities. Every day, we strive to transform healthcare with trusted, caring solutions. In following, we're going to play a short video showcasing how Anthem Blue Cross and Blue Shield has been doing that, especially for the state of Indiana. Unfortunately, it looks like our video playback has not been fully loaded for this session, so we'll do so at the end. I'm going to go ahead and transition it now to our MC Blake Wood to introduce our speakers for this afternoon.
Thank you very much, Sunny. Good afternoon, everyone. This session is on tobacco prevention. Part 1, entitled "The Doctor Will See You Now," highlights from the 2020 Surgeon General's report on smoking cessation, will be presented by Kayla Hsu. Part 2, entitled "The Hidden Harms of Tobacco Use," will be presented by Debbie Buckles. Our presenter for Part 1, Kayla Hsu, serves as the Community Outreach Manager for Rethink Tobacco Indiana. She works with healthcare providers and partners around the state to help behavioral health treatment facilities to integrate evidence-based tobacco treatment approaches into their system of care and develop comprehensive tobacco-free grounds policies. Prior to joining Rethink Tobacco Indiana, Kayla worked as a quality improvement advisor with a nonprofit healthcare quality improvement consultancy and also as a Medicare quality improvement organization. While working on a contract with the Centers for Medicare and Medicaid Services, she worked to improve healthcare around Indiana, specifically relating to behavioral health integration. Kayla is a trained tobacco treatment specialist by the University of Massachusetts Medical School and a certified UMass TTS trainer with experience in planning, coordinating, and delivering TTS trainings around the state. Kayla serves on the board of directors for the Indiana Society for Public Health Education. She is also a certified health education specialist and has earned the National Certificate in Tobacco Treatment Practice. Kayla holds a Master of Public Health degree from Indiana University, Bloomington. Oh, my apologies, my screen wasn't advancing. Well, that's it for Kayla's intro. Kayla, we'll turn the floor over to you, and we're looking forward to your presentation.
Thanks, Blake. I think I'm sharing my screen now, so sorry, I think maybe that's why you lost control. But hi, everyone. Thanks for having me today, this afternoon, right after the lunch hour. So today I'm going to talk about the highlights from the Surgeon General's report on smoking cessation. So here are today's learning objectives. Going to talk about the tobacco use patterns among adults and youth, share the Surgeon General's report findings on the health benefits of cessation, comparing evidence-based treatment strategies, discussing some strategies that can be implemented at the clinical systems and population level, and then sharing some local and national resources available. So the first Surgeon General's report on smoking and health was released by Surgeon General Dr. Luther Terry in 1964. So this was the first official report that really concluded cigarette smoking is the cause of lung cancer in men, a probable cause of lung cancer in women, and the most important cause of chronic bronchitis. And so this was the release of the first in a series of steps that we're still taking today to really diminish the impact that tobacco use has on our health. And so we know that tobacco use is still the leading preventable cause of disease, death, and disability here in the U.S. We have more than 480,000 deaths each year attributed to a tobacco-related illness or disease. But what many people may not be aware of is that almost half of those deaths are among adults with a behavioral health condition, so mental health condition or substance use disorder. And so looking at where we are today, we kind of got to look at where we come from. And so this is showing the adult cigarette smoking trends from 1965 to 2018. And so as you can see, we've come quite a long way with male smoking at about 52% and female smoking at about 34% in 1965. And so although that we've made considerable progress since the release of the first Surgeon General's report, we still have 13.8% of our adults that currently still smoke cigarettes. And so of this population, we know that majority of people want to quit. Almost 70% want to quit smoking completely. And so we know that nicotine, the nicotine that are in tobacco products, it is highly addictive, as such as drugs like cocaine and heroin. And nicotine activates our body's natural reward system, which then reinforces the behavior, smoking, which makes it harder for people to quit. And so previously it was thought that on average it took someone around 10 times to try to quit to be successful. But we now know that that is severely underestimated and actually takes on average around 30 times for someone to quit smoking successfully. And so if that's the case, then we need to ensure that we are providing appropriate evidence-based interventions and consistently offering these interventions to all tobacco users so that we can really be setting our clients and patients up for success. And so this graph here shows the trends in our youth tobacco use here in the United States by product type. And so as you can see, last year, around 36.5% of high schoolers, so that can be like one in three people, 1 in 3 students, currently use any tobacco product with, as you can see, ENDS, which is electronic nicotine delivery systems, or e-cigarettes, being the most commonly used tobacco product of high schoolers. And so this has been a dramatic increase over the years. You can see with the e-cigarette use as it began to rise within the last few years. And so it's really led to an overall increase in tobacco product use among youth. And then, of course, really erasing all the gains that we've previously seen in terms of tobacco treatment and prevention, which led to last year in 2019, led to the Surgeon General also declaring a youth e-cigarette epidemic here in the US. And so we know these products are not harmless. And of course, nicotine exposure too can really negatively affect youth. Their brains are still developing. And we know more than likely, the youth who do use e-cigarette products, they have up to 6 times more likely odds of initiating combustible or traditional cigarette use. So it's important that we still focus the work on prevention and reduction of tobacco use among youth as well. So this 2020 report on smoking cessation was released earlier this year in January, and it's the 34th Surgeon General's report on tobacco since the initial report in 1964. And so this report specifically focuses on cessation. And so it's the first one to do so since the last report that focused on smoking cessation was in 1990. So this is, 30 years ago. And so the purpose of this year's report, the 2020 report, is to really update and expand upon that 1990 report, based on new research findings on smoking cessation, what we've learned in the past 3 decades. It really illustrates how new interventions to quit, new pharmacological interventions that we have out there, different things that clinical and health systems can do, such as the 5 A's or ask, advise, refer. It also discusses population-based policies too that can really support and promote tobacco cessation, like mass media campaigns. And then it also addresses some new and emerging issues, especially with evolving products like e-cigarette and vaping products and heat not burn products. Those are newer. And so, really expanding upon what the research shows to really support and help make quit attempts more successful. And so while we've had such a decrease in adult cigarette smoking, there are considerable disparities that do persist in the prevalence of smoking. And so there is a higher prevalence in some groups over others. And so as you can see, those with the GED certificate, serious psychological distress, those that are uninsured or on Medicaid, the LGBTQ plus community, and those American Indians, Alaska Natives, they have disproportionately higher rates of smoking. If you recall, in 2018, it was 13.8% of our general population were current smokers. And so you can say that these are significantly higher than that. And so as with many health behaviors and chronic diseases, there are several risk factors for smoking that are highly correlated. So one example that the report points out is that the smoking rate for those with serious psychological distress who completed 9 to 12 years of education, but they did not have a high school diploma or a GED. So that smoking rate was 58.5%, but the smoking rate was 32.7% for those with serious psychological distress that had at least a high school education. So people with multiple risk factors typically have a higher prevalence of smoking than those with a single risk factor. And so similarly, the prevalence of key indicators of smoking cessation, so that's going to be your number of quit attempts, receiving advice to quit from a healthcare professional, and using cessation therapies like medications, like counseling, like the quit line. The report also found that there are disparities that exist with the key cessation factors as well, having a lower rate of use in some vulnerable populations. So one example is white non-Hispanic adults were more likely to receive advice to quit than were Asians, American Indians, Alaska Natives, or Hispanics. And even more so, whites also had a higher rate of using counseling and or medications for quitting than did Blacks, Hispanics, and Asians, although Asian population and Black population had higher rates of having more quit attempts compared to whites. So they're having more quit attempts, but they're not using they're not using what is shown to be more effective to help people to quit more successfully. Persons with graduate degrees, so education, that one's pretty significant too as a disparity. So people with graduate degrees have a higher rate of having past year quit attempts than people with a high school diploma or no diploma. And for those adults that use tobacco, so tobacco users that visited their primary care physician, they were more likely to receive counseling, so at about a quarter of their visits, than were those other tobacco users who saw a doctor other than their primary care physician. And even more so, those who specifically saw a cardiovascular disease specialist, they were more likely to receive counseling on tobacco use than were patients who visited a general or family doctor, obstetrician and gynecologist, and another big one, a psychiatrist. And we know that adults with behavioral health conditions too smoke at extremely disproportionately high rates as well, yet they are not being advised to quit as much or receiving that counseling for tobacco use. In terms of interest in quitting, so interest in quitting is highest among those adults that are 25 to 44 years old, and it's generally lowest among those that are 65 and older. And so, but the younger smokers that are younger than 45 years old, they're less likely to be advised to quit and also to use effective cessation treatment. So again, this is just illustrating that disparities do exist in terms of even with quitting. And so while receiving advice to quit from a healthcare professional, it has increased since the 2000s, but still 4 out of 9 adults who smoke did not receive advice to quit when they saw a healthcare professional in the past year. And so we know this is simple to do in healthcare settings, to give the advice to quit, and it can have a big impact on someone potentially starting to have a quit attempt, or at least being ambivalent and thinking about their own tobacco use. And another major conclusion of the 2020 Surgeon General's report was that more than 3 out of 5 adults who've ever smoked cigarettes have quit. So it is possible, but although a majority of those smokers that make a quit attempt each year, less than 1/3 use FDA-approved tobacco treatment medications or counseling to support the quit attempt. And we know that those medications and counseling are evidence-based strategies. We know that they're also cost-effective, and they only increase the likelihood of someone being successful in their quit attempt. So looking at the health benefits of quitting, we know that smoking harms nearly every organ in the body. But of course, quitting smoking has a ton of different benefits. Really, this report highlighted a few of them. So it can help to lower the risk of 12 different types of cancers. And you can see them here on the graphic. So lung cancer, pancreatic cancer, bladder, and even 10 to 15 years after someone quits, the risk of developing lung cancer drops by half compared to the risk of those that are still smoking. Quitting also helps to lower the risk of cardiovascular diseases, which is the leading cause of death in the U.S. And smoking only increases the likelihood of having atherosclerosis, hard to say, so which decreases the blood flow. Also, increases the likelihood of having heart attacks, heart arrhythmias, heart failure. Quitting smoking also helps to lower the risk of COPD, so chronic obstructive pulmonary disease. And we know that smoking is the leading cause of COPD. And so unfortunately, there is no cure for COPD, but quitting smoking can help to reduce or delay the loss of lung function and help to lower the progression of COPD. And so it's long been known that smoking it's harmful to reproductive health. We do know that it causes preterm birth, lower birth weight, increase in birth defects. It's also linked to increase in fertility in both men and women. But specifically, the Surgeon General's report points out that quitting before or early in pregnancy can help reduce the risk of having preterm delivery. And so overall, we know that quitting smoking helps to reduce the risk of having premature death, helps to improve health, and really enhance overall quality of life. Even adding as much as 10 years to someone's life expectancy. And of course, quitting sooner is always going to be better than quitting later in life, but it's never too late to get the benefits of tobacco recovery. And so the 5A's model for treating tobacco use and dependence, this is really the gold standard for delivering tobacco cessation interventions. So the 5A's, they're ask, advise, assess, assist, or range. And so really the first one is asking. This is asking all patients about tobacco use. So it's identifying all tobacco users and documenting that into the electronic health record at every visit. It's really ideal to do that, every patient at every visit, even if you see them once a month, because things could change. And it should just be, as a part of the clinical workflow, like taking someone's vital signs. And so after you ask, you're going to advise all of those who use tobacco to quit. So it's best to do that in a clear, strong, and a non-judgmental tone, and really in a personalized manner if you can. So it can be as simple as, hey, do you know quitting smoking is the best thing that you can do for your recovery? It can really help to lower the likelihood of having recurrence of symptoms. That's advising to quit. The next one, assess. So you're then going to assess your patient's willingness to make a quit attempt. Again, can be as simple as, have you ever thought about quitting, or would you be interested in quitting within the next month? So there's going to be a couple of different things, for those patients that are ready to quit. You can begin discussing, different treatment options, like the different medications, offering that, maybe writing a prescription for some non-nicotine medications. And then referring, you can provide the counseling or referring to counseling. Maybe at your organization you have a tobacco treatment program and you're able to do that, or it's referring to additional help, which could be the Indiana Tobacco Quit Line. For those who are not willing to quit at the time that you're asking that, you should definitely be talking about a different way, their ambivalence, utilizing those motivational interviewing strategies to discuss, maybe why they don't want to quit right now, but really important to get their motivation up for that, get them to really be thinking and ambivalent about their tobacco use, and then offering that standing order that, hey, we're always going to be here if and when you are ready to quit, though. We'll talk about this next time I see you. The next one is assist, which is then, assisting with that quit attempt. There's medications counseling. It could be assisting with the referral, helping with that. And then the last one, finally, is arrange. So it's arranging for follow-up contact with maybe the patient that's quitting, contacting them the week of their quit attempt, or for those who are not ready to quit. Again, it could be arranging to discuss this again at their next appointment with you. And so in terms of the Surgeon General's report findings related to tobacco interventions, so behavioral counseling, it does increases someone's chance of quitting successfully. And then the FDA approved tobacco treatment medications, they are effective also in helping people to quit. But the gold standard, the secret sauce, I say, to help people to quit most successfully is combining that behavioral counseling with those tobacco treatment medications. That increases the likelihood of someone achieving abstinence, of having that long-term tobacco recovery. That's really going to set your patient up for the most success. And so again, they're both effective, but combining them is the gold standard, and it's going to make the treatment more effective than either method alone. So these are behavioral and psychological strategies that have been shown to be effective in the report to treating tobacco use and dependence. You have your behavioral therapy, which can be sort of like practical counseling, looking at strategies to cope with different triggers, manage cravings, helping to reduce some of those withdrawal symptoms. There's cognitive therapy, so CBT, cognitive behavioral therapy, kind of getting at those cognitive factors that we have automatic thoughts that might reinforce some behaviors. There's motivational interviewing. That one is huge. I am such a proponent of motivational interviewing. You can use it with a whole lot, not just tobacco, but it really is a patient-centered approach, non-judgmental, highly collaborative. It can be really great when using motivational interviewing for those who are not ready to quit yet. It's really, dealing with that ambivalence where people are kind of, I might want to quit, but I kind of like this. So MI can always be used. It's really great. There's acceptance and commitment therapy that the report talked about, really focusing on how changing psychological events, directly, and then commitment to what someone values in themselves and leveraging those values to help motivate them. And then contingency management and monetary incentives. So, there is evidence to support that. They work to help people, to motivate people to change and to, have outcomes, like successful outcomes, such as smoking cessation. But when the incentives are gone, that's when people typically return back to the old behavior. So it's really important to think about how to maintain that when the incentives are gone. And also how you're framing the incentive. Are you thinking of it as a reward, or are you kind of framing it like a punishment too? So it's important when it comes to those incentives. And so the current evidence-based treatment approaches for smoking cessation, they include several behavioral treatments. So, individual, group, telephone counseling, and those FDA-approved medications I mentioned earlier. So these treatments have been shown to be effective when delivered through a wide variety of settings over several different types of modalities and platforms to a wide variety of groups. Even reaching those who may be disproportionately affected, like our low-income population or those with comorbid conditions. So self-help materials In general, self-help materials that are not tailored to a particular person or a group, they have very limited effectiveness when they're not coupled with an in-person counseling session or technology-based interventions. So if you're going to have kind of like a general untailored handout, you definitely want someone to be working with that patient. Research does show that there's a small amount of effectiveness for tailored materials, especially when they're based on specific concern by smokers. And the benefit too of self-help materials is, they're relatively inexpensive, inexpensive to produce or provide. And there's a lot of different websites out there that you can usually download them for free too as well. Brief advice. So the U.S. Preventative Service Task Force, they're the ones that give us recommendations on when we should do healthcare screenings, things like that. They give a grade A recommendation to deliver brief advice to all adults that use tobacco products. And so, most people do trust their doctors and expect them to address their tobacco use. And research has shown that patients are more satisfied when their provider does discuss quitting with them, although in the past year, only around 57% of those who smoke received advice to quit from a healthcare professional. Face-to-face counseling, so either individually or through group, there's been well-established effectiveness for having face-to-face counseling, and we know individual counseling, it is more effective than brief advice or self-help materials. And in terms of intensive counseling, so this is going to be counseling that's greater than 10 minutes usually, and it's usually provided by a clinician who's had kind of specialized training. So maybe it's a tobacco treatment specialist. So we know that there is a dose-response relationship with the intensity of counseling and quitting success. So with the greater the intensity, so longer counseling sessions, more sessions, the higher the likelihood that someone will quit. And so there is also research to support the effectiveness of behavioral therapy that's delivered through non-face-to-face approaches, especially in the technology world that we live in today. And so it really can help us to remotely monitor, track, and respond to and deliver these tobacco treatment interventions. In 2016, 95% of American adults owned a cell phone, and 77% of which were a smartphone. And so with technology, especially in the COVID world that we're living with now, we're seeing how we're able to adapt technology for something such as a conference like we're in right now. So they can really help to remove or reduce time. Transportation, that's a really big one, especially here in Indiana. Childcare issues too can remove that as a barrier as well, which could be a barrier for someone to going to face-to-face counseling. So the technology can really hopefully help us to have a more widespread reach with these interventions. Although there is concern, of course, that in certain rural areas and lower income populations may not always have access to technology. So first, looking at the telephone-based quit lines. So like 1-800-QUIT-NOW, our state quit line, the Indiana Tobacco Quit Line, they can offer multiple sessions for proactive tobacco counseling. And so that has been shown to significantly boost smoking cessation rates. And again, there is some evidence that does support a dose response effect with quit lines. So again, the higher number of proactive calls that a person has, the more likely that they can be successful with their quit attempt. Another huge benefit too is that they're free. And so with the Indiana Tobacco Quit Line, callers with a behavioral health condition, they can get up to 12 weeks of free combination nicotine replacement therapy. And of course, they're getting assistance and a higher number of calls. They get 7 calls with assistance from their quit coach. So that's really fabulous about our quit line. And that's not the same for every state either. The text-based programs. So short text message services about smoking cessation. The Surgeon General's report found that they are independently effective in increasing smoking cessation rates, especially if they're interactive and they're tailored to the individual and they're able to tailor to the individual text response when someone texts back. And of course, the benefit of a text program, they're generally low cost. And again, since it's doesn't have to be a smartphone, it's text message. 95% of adults have a cell phone, so again, can potentially have that larger reach. And especially with populations like youth who, may prefer text message communication over other forms of communication. Web-based programs, so about 88% of adults have access to the internet. There is some evidence of effectiveness of web-based interventions, but it's mostly mixed. So there's evidence to support the web-based interventions if they contain behavior change techniques and interactive components. Smartphone application. So this intervention delivery method, it uses a smartphone mobile app as a platform, which it really combines the text message with the web-based program into one to be really interactive and to have that visual cessation program. And in 2013, researchers, they looked at all of the apps, on iOS and Android. There were 252 on the iOS system and 148 on Android, and to look at their adherence to the clinical practice guidelines for treating tobacco use and dependence. That's really, I call it the Bible for tobacco treatment, but it gives us evidence-based recommendations on what is proven to work. And overall, there's really low adherence to these mobile apps that they use evidence-based approaches that are similar to the clinical practice guidelines. And so while there's a variety of different treatment options out there, majority of people, they still, begin to quit with no help, unaided, without using, behavioral counseling or those medications that have been shown to be effective. And so here are the 7 FDA-approved medications for tobacco treatment. Those that are listed in green are nicotine replacement therapy, or NRT products. The 2 listed in the blue are non-nicotine medications. The ones on the left are available OTC, over the counter, and the ones on the right, the nasal spray, the inhaler, bupropion SR, varenicline, those are available with the prescription. And I will say our Indiana Medicaid program does cover all 7 FDA-approved medications, but they just may have to have a prescription for that. So even though you could buy the nicotine patches over the counter, in order to use, your health insurance benefit, you might need someone to write a prescription for that. And good news, we do have a standing order where our pharmacists here in Indiana can write prescriptions kind of in-house for the tobacco products. And so I mentioned combination therapy earlier when talking about the Indiana Tobacco Quit line, but it really combines the use of the different tobacco treatment medications. So we know that combination NRT does work more effectively than single use and monotherapy, than just using one medication. And so the typical combination is using a long-acting formulation, which is typically the nicotine patch. It gives that slow, steady stream of nicotine throughout the day, and then pairing it with the short-acting medication that's going to help to manage those cravings and withdrawal symptoms throughout the day, because none of the medications are going to give that big rush of nicotine like a cigarette normally would. But the combination therapy can really, really help, especially for those that are more heavily dependent. E-cigarettes, this is always the topic du jour. I'm just going to spend a little bit about this, just highlighting what the report said about e-cigarettes, but there's no standardization. They vary in their ability to deliver nicotine to the body. Although some of these devices, they do have a rapid delivery of nicotine similar to a traditional cigarette. But more than half of adults that use e-cigarettes also smoke traditional cigarettes. So we call that dual use, using more than one product. Excuse me. But e-cigarettes, they're appealing, and they can really help to maintain the nicotine addiction because they do mimic traditional cigarettes in many ways. For some of them, the first generation, the ciga-like size and appearance. The method, they're inhalation, they're inhaling that, producing that smoke-like aerosol. It is not harmless water vapor. And kind of the taste and the ritual behaviors that are associated with smoking, as well as, again, that high nicotine content is only increased over time. So again, as I mentioned, these products are not harmless. They have been associated with other health effects besides, youth initiation and the youth vaping epidemic. You might recall that that lung injury, the EVALI that was here in Indiana. We did have some folks that did unfortunately die from EVALI. It was a big national scare as well, and it was some of the vaping products that had THC in them and vitamin E acetate as well. And so, with these devices, they're ever changing, but really there's no proven level of safety or effectiveness for these devices to be a quit smoking aid or tool. They are a tobacco product regulated by the FDA as a tobacco product in order for these companies to make a large profit. And so, so the report concluded that there's inadequate evidence to infer that e-cigarettes increase smoking cessation. Should stick with what we know to be effective, which is the counseling and those FDA-approved medications. So switching gears a little bit, looking at the clinical system and population level strategies that promote smoking cessation. And so, these really help the person that's quitting smoking at 3 different levels: the clinical level, health system, and population, which is similar to the CDC's what's called the 3 buckets framework. And so a combination of these strategies across the 3 buckets is really optimal for smoking cessation to really increase that motivation and support in helping people to quit and creating an environment that's supportive for people to quit. And so clinical and system level strategies typically target the quitting behavior directly. They usually focus on the use of effective treatments. And for looking more in depth at the different strategies that they include. So it's integrating, tobacco treatment into the clinical workflow. It could be implementing policies and protocols to make sure everybody's screened and provided treatment, and promoting what we know to be evidence-based, and just really, implementing policies. It could be a tobacco-free policy at your organization that could really help to further an environment that's supportive. The population level, so this is going to be those that are at the macro level that supports that environment for helping someone to quit and really trying to lower the barriers and make it less challenging for someone that does want to quit. So you can see here a couple of different strategies is, increasing the price and the tax of tobacco products like cigarettes and the e-cigarettes. Funding tobacco control programs so that they can do more work, the boots on the ground, and have more funding for local organizations that may be doing this work. Mass media campaigns have been shown to be effective, promoting what is effective of, our Stay Quit line. You can get 12 weeks of free combination therapy. And of course, promoting those tobacco-free policies to smoke-free air ordinances as well at the population level. All right, so before I wrap up, again, I wanted to highlight the Indiana Tobacco Quit Line. So hopefully you all might be familiar with this, but if you're not, really great refresher. It's free and it's confidential telephone support to help Hoosiers quit. And it can even be for e-cigarettes as well. They have a youth program for youth ages 13 to 17 years old. They can enroll. And most people that enroll receive a personal quit coach. They get quit guides. They have the text message options. We talked about that. And an online forum of, videos and tools online to see what it's like to get a call from the quit line. And they can always call unlimitedly to 1-800-QUIT-NOW. And then the general program gets 2 weeks of free nicotine replacement therapy. But again, if someone's calling and they have a behavioral health condition, there's no medical paperwork to provide that justification. It's, self-attestation, just kind of saying yes when someone reads off what condition it may be, and saying yes, I do think that would prevent a challenge for me. So they get, again, that 12 weeks of combination nicotine replacement therapy to support their quit attempt. Oops, went really too fast. So some resources here. So to learn more about the Indiana Tobacco Quit Line, please visit quitnowindiana.com. If you want to learn more about the Surgeon General's report, It's a huge report. It's actually what my computer's on right now, lifting it up a bit. But they have an executive summary. It's shorter. They have fact sheets, geared towards, payers, insurance payers, the system level, and also have a really nice guide for patients and clients that want to quit as well. So it can kind of be a unique opportunity to say, hey, the Surgeon General came out with a new report today. Can I talk to you about this? Here are government resources too for someone to quit tobacco. So they're all the smokefree.gov, but again, tailoring it. So finding what program is specific to the patient you're working with. And then more additional resources. And then you can see the Truth Initiative, RX for Change. Purdue College of Pharmacy has a really great CE program for health professionals or clinicians that are really wanting to learn more about evidence-based tobacco treatment. So, thank you, and I will pass it back to Blake.
Kayla, thank you very much for presenting this important topic for the symposium. Our next segment for tobacco prevention is part 2, the hidden harms of tobacco use, presented by Debbie Buckles, the Program Director of the IU Simon Tobacco Control Program. Ms. Buckles has received her bachelor's degree in respiratory therapy, the National Certificate in Tobacco Treatment Practice, and serves on the Council for Tobacco Treatment Training Programs. Employed by the IU Simon Cancer Center since 1997, the first 13 years of Ms. Buckles' career was dedicated to helping individuals overcome their tobacco addiction. Since 2008, Ms. Buckles has dedicated her career to the Rethink Tobacco Indiana project, focused on tobacco cessation systems change in mental health and substance abuse centers across Indiana. Recipient of a grant from the National Cancer Institute's Moonshot Initiative in 2017, allowed her the opportunity to develop a tobacco treatment program for cancer patients. Currently, she oversees the IU Simon Tobacco Treatment Program and Rethink Tobacco Indiana. With more than 20 years in the field of tobacco treatment, she has coordinated and developed training programs for healthcare professionals and laypersons across the state, worked on multiple research efforts, and been a leader in Indiana. Debbie, thank you for being with us today. We're now ready for your presentation.
And Debbie, if you want to switch the display settings, you can, in the middle, drop down there in the display settings, and you can swap the view at the upper left-hand corner.
I think I'm set up, so, okay. All right. So thank you for allowing Kayla and I to present today. Kayla and I work together on Rethink Tobacco Indiana. We'll talk more about that in just a minute towards the end of this presentation, but I do want to show you our objectives for today. We're going to talk a little bit about some of the existing disparities in the prevalence of tobacco use among persons with mental health and substance use disorder, along with talking about the relationship between tobacco products and COVID-19, and also how tobacco impacts the metabolism of many commonly prescribed medications. And then we're going to finish up today talking a little bit about a valley, which Kayla mentioned as well. So that's where we're going to start, or what we're going to talk about today. And we're going to start with a little trivia here. So obviously I've given you the answer here, but people with mental health or substance use disorder are more likely to die of a tobacco-related disease than from their behavioral health condition. And this may be surprising to some of you. Some of you probably not, but this may be a little bit surprising. Here's another trivia question for you. And if you'd like, you could type in the chat box your answer to this question. So smoking is associated with A, greater depressive symptoms, B, reduced depressive symptoms, C, greater anxiety, or D, reduced anxiety, E, which is A and C, or F, B, and D. And let's see if anybody's, give you a second to type in your answer there to the chat, but I think it's important just to raise these questions and get you all thinking about tobacco and the relationship between mental health disorders. So the answer here is, drum roll please, F. So reduced depressive symptoms and reduced anxiety, believe it or not. So cigarette smoking it is a major issue. As the former U.S. Surgeon General C. Everett Koop stated, cigarette smoking is the chief single avoidable cause of death in our society and the most important public health issue of our time. While he made that statement back in 1982, it is sadly still very true today, more than 2 decades later. Kayla talked already about the Surgeon General's report, but this is a very key, important fact that we have learned a lot over the last 54 years of the Surgeon General's report, 56 years, I should say. And as she mentioned earlier this year, we've had our most recent Surgeon General's report on smoking, and it brought to light a lot of facts. Interestingly, she mentioned the first Surgeon General's report, as I said, came out in 1960, and she said came out in 1964, and that was Dr. Terry Luther. Interestingly enough, he was from Indiana, and so is Dr. Adams, who just released this most recent report. So we've had 2 Surgeon Generals release reports about smoking that were from Indiana. And the bad news is that disparities still persist. We have many different subpopulations with higher smoking rates and lower rates of smoking cessation. I'd like to ask many of you watching today if you see any patients from these patient populations or these groups. And if so, what do you think you can do to change the higher smoking rates and the fact that fewer of them quit smoking? I'd like you to ponder that just a little bit as we finish the presentation today. Indiana has historically had very high smoking rates, and nothing has changed. We still are one of 13 states that has consistently ranked in the top 25% of US adult smoking since 2011. And because of this, it looks like my slides are a little out. Because of this, Indiana has been identified as part of what's called Tobacco Nation. And this is a collection of states with smoking rates that exceed not only the national average, but that of many countries with the highest smoking rates in the world. And as you can see, Indiana right here and smack dab in the middle of Tobacco Nation. The Truth Initiative has termed this group of states, as I've referred to, as Tobacco Nation. And these states share not only higher tobacco use rates, but poorer health outcomes as well. In addition to the poor tobacco-related health outcomes are many comorbidities and co-occurrences that often accompany tobacco use. Smokers in the Tobacco Nation report higher rates of frequent mental distress, frequent physical distress, and poor mental health. Tobacco Nation smokers report 29% more poor physical health days and 40% more poor mental health days than their average non-smoking neighbor. So this brings to light the fact that even though we do have declining smoking rates, it is still clear that we have much work to do in the fight against tobacco. I'm sorry, I gotta go back 2 slides here. But the tobacco landscape is always changing, and this is why we have an ongoing issue with tobacco. We don't want to keep playing this game of public health whack-a-mole where use of certain tobacco products decreases, but use of other tobacco products increases. So while we know there are a lot of different tobacco products out there, we also know there's a lot of variation and change within the different types of tobacco products on the market. And e-cigarettes are just a great example of this. So let's switch gears and talk a little bit about tobacco among the behavioral health consumers. We know that individuals with behavioral health conditions are 3 to 5 times more likely to smoke. They smoke more, and they die 10 to 25 years earlier. As I just mentioned, individuals that use tobacco often experience co-occurring behavioral health conditions. And as you can see here, the most prevalent co-occurring disorders are substance use disorder at 49 to 98%, alcohol abuse at 34 to 93%, and of course, schizophrenia at 62 to 90%. And it isn't just an issue of high prevalence, but those who do smoke are smoking very heavily. This study examined a number of psychiatric diagnoses among individuals and compared them to how much they smoked. And what you see here is individuals with no psychiatric diagnosis were about 3.5 times among those with zero diagnoses, only had about 3.5% were heavy smokers, whereas people with 4 or more psychiatric diagnoses were 5 times more likely to be heavy smokers. We also know that tobacco use is the leading preventable cause of death and disease, not just in the general population, but even more so in individuals with mental illness. Kayla mentioned this in her presentation as well. So we have about 480,000 people dying every year from tobacco. That's more than the number of deaths if you combine the causes of death of AIDS, obesity, alcohol, motor vehicle accidents, homicide, drug-induced, and suicides all combined. And about half of these individuals are individuals with a mental health disorder. However, we do have this study, which is a meta-analysis of 26 different studies that show that people with poor mental health, the mental health situations or conditions do improve with quitting smoking, especially diagnoses like anxiety, depression, mixed anxiety and depression, as well as stress. And think about it. Why do most people report smoking? What do they get? What is the benefit they report from smoking? It's to reduce stress and anxiety. So isn't it intriguing that anxiety and stress are reduced after quitting? I find that very, very interesting. Part of it's because of the withdrawal that people go through when they're constantly smoking. And as they need another hit of nicotine, they feel these withdrawal symptoms, which feel very much like anxiety and stress. So what do we know? Well, we know that tobacco use is strongly associated with dependence on abuse of alcohol, marijuana, and other substances. We know that smoking exacerbates many symptoms of behavioral health conditions, and that smoking has been linked to an increase in depression, anxiety, greater likelihood of psychiatric hospitalization, suicidal ideation, and drug and alcohol use relapse. We also know, excitingly, I find this exciting, I hope you do too, that tobacco dependence treatment during addictions treatment is associated with a 25% increased likelihood of long-term abstinence from alcohol and illicit drugs. Many people are surprised by this fact. In fact, most people in the behavioral health world feel the opposite is true. I think it's important to bring light to this fact. We also know from recent studies that readiness to quit among individuals with mental health indicate over 20% are intending to quit in the next 30 days, and another 40% intend to quit in the next 6 months. So this is really important when we talk to providers to encourage them to talk to patients about quitting smoking. Adults with behavioral health disorders who smoke are just as ready to quit as those in the general population. And what's also important is that studies have also shown there's no relationship between severity of psychiatric symptoms and intention to quit. A meta-analysis of 38 studies with more than 16,000 mental health professionals, found that about 40% felt there were barriers to treating tobacco dependence, and about the same number had negative attitudes toward smoking cessation, but about 45% had permissive attitudes towards smoking. We know that the lack of training in tobacco treatment techniques plays a huge role in people feeling comfortable enough to reach out and address this issue with their patients. A study of psychiatric residency programs found that all programs provided training on addictions, but only half provided training on nicotine dependence or tobacco dependence. And those programs that did not have tobacco training programs felt it was tobacco was a lower priority. And I think that's key because really, if more than half of the patients being treated are dying from a tobacco-related illness, not a mental illness, is that really a low priority? The beliefs of providers doesn't really match with those of patients with behavioral health conditions. As I just showed you, more than 40% intend to quit in the next 6 months and 20% in the next month. So we're going to switch gears and talk a little bit about tobacco use and medication. I know we're running a little behind, so I'm going to try to make up some time here. But suffice it to say that many medications, especially some of the psychotropic medications, are impacted by tobacco smoke. It's the hydrocarbons of the cigarette smoke that decrease the effect of many of these medications. So medications such as antipsychotics and antidepressants. And the result is that patients are required that higher doses of the medications are required to achieve the same therapeutic levels in patients that smoke. Again, the drug interaction effects because of the tobacco smoke. It's not the nicotine, but it's the actual smoke or the tar of the nicotine of the cigarettes. And people that smoke, as I mentioned, need higher doses. And why might that be a problem? Why are we concerned if patients need higher doses of their medications? Obviously, because we have increased neuroleptic side effects then, such as drowsiness, dizziness, weight gain, nausea, dry mouth, but also because of increased cost. These medications that have a higher doses cost more at the pharmacy. And then, of course, these two factors play into the fact that then patients don't want to take these medications. So medication compliance is at risk as well. So again, it's important to think about the medications and the metabolism of these medications. And one of the interesting things is that caffeine, the metabolism of caffeine is also impacted by tobacco smoke. So if a patient is quitting smoking, they're used to maybe smoking or drinking a pot of coffee a day. The effects of caffeine are going to be more compound or more concentrated, so they're going to feel that caffeine more when they're quitting smoking. So these are things we need to be cautious about, and providers should be aware of when their patients are quitting smoking. For instance, if they're on some of these medications and a patient goes inpatient, or a patient decides that they on their own are going to quit smoking, these medication dosages may have to be adjusted, because if their medication is being metabolized faster, they're on a higher dose and they quit smoking, it's more than likely that dose will have to be decreased when they quit smoking, or if they are incarcerated, or as I said earlier, or if they're admitted inpatient. So let's switch gears here a little bit. We're going to talk some more about vaping. Kayla touched on this a little bit too, but these battery operated devices are used to deliver a variety of chemicals, obviously some including nicotine and or cannabis. However, anything that can be liquefied can be added to these devices. For example, bath salts, date rape drugs, and many, many more. And not to mention, the devices are often tampered with to expose the heating element, which then intensifies the effect. It's often called dabbing, dripping, hacking, not just vaping anymore. So we can't just ask our patients the question, do you smoke? Or do you vape? We really instead should be asking what tobacco products, including things like Juul, Puff Bars, Soren, tanks or mods, vape pens, what types of these products have you used in the last 30 to 90 days? One thing that's important to notice is that we do see more patients with mental health conditions using e-cigarettes. And they're more likely to have tried e-cigarettes, they're more likely to currently use e-cigarettes, and more likely to anticipate future e-cigarette use than adults without mental health diagnoses. People reporting psychological distress are twice as likely to use cigarettes, 3 times as more likely to use only e-cigarettes, and 4 times as likely to dual use. And remember, dual use is cigarettes and e-cigarettes combined. This study also highlighted some facts about different types of behavioral health treatment. For instance, in this study, 60 patients with schizophrenia, 37% of them had tried e-cigarettes. Of 188 veterans, 31% used e-cigarettes. And then of 231 patients in community mental health centers, 22% had used e-cigarettes. And just so we're clear, e-cigarettes are deemed by the FDA as a tobacco product. They are not a quit smoking aid. These, especially the products that do contain nicotine, the nicotine is from the tobacco plant, and that's why they are deemed as a tobacco product. And Kayla mentioned this too, but the long-term effects of e-cigarette use is unknown. But our recent research does show us that there are negative effects on the lung and cardiovascular health, and we'll talk more about this in just a second too. But we do see chronic cough, phlegm, and bronchitis, as well as asthmatic diagnoses in these patients that are vaping. The U.S. Preventative Service Task Force does not recommend e-cigarettes as a tool for smoking cessation. And I do know there's a lot of confusion out there about this topic, so we just wanted to make it clear. So let's talk a little bit about COVID-19. There are a significant number of groups at higher risk, and these are typically individuals that have comorbid conditions or chronic health conditions such as heart disease, lung disease, COPD, diabetes, obesity, these kinds of things. So smoking and vaping does negatively affect the lungs and the immune system by causing inflammation. One other population that's affected is those individuals with substance use disorder. And again, that's because of the effect on the respiratory and pulmonary health, access to treatment, and homelessness. And then, of course, individuals with behavioral health conditions may also be at greater risk of tobacco, alcohol, and other substances used to cope with stress. So there's a lot of factors we need to be aware of, and that all of these things combined make this population more vulnerable. Again, and that's because of the suppressed immune system. So quitting smoking may help reduce the risk of serious illness. So not only are they more likely to contract COVID-19, but they're more likely to have the more severe symptoms of COVID-19 as well. Part of that is because individuals are likely to share their products. So you might see them sharing a hookah or vape pens or different tobacco using products. But these individuals bring their hands to their mouths more frequently, which can also transfer the virus. I wanted to bring this study to light because this was just released a few weeks ago from the University of Stanford that found that individuals with COVID diagnosis were 5 times more likely to be ever users of e-cigarettes and 7 times more likely to be dual users. So again, dual using meaning cigarettes and e-cigarettes. I know Kayla mentioned EVALI. We're going to talk a little bit about that. What is EVALI? EVALI is the e-cigarette vaping associated lung injury illness that we saw last fall and winter. It is an inflammatory response in the lungs that's triggered by inhaling a substance. It can appear or occur as an pneumonia or damage to the tiny air sacs known as alveoli, or as an inflammatory reaction known as pneumonitis. It is a diagnosis of exclusion because we have no specific test or marker at this time to be able to say, oh yeah, I'm going to give this patient this test and find out if they have it. But it's important to identify this quickly so that we can treat the symptoms and be successful in our treatment. The symptoms of EVALI are kind of confusing. Believe it or not, obviously there's the respiratory symptoms, the cough, shortness of breath, and chest pain, but also GI symptoms. So 85% of patients did exhibit the GI symptoms. Indiana did document some statistics related to EVALI, and they identified 60 confirmed EVALI cases and another 68 probable cases and 6 deaths. What you may not be able to see on this slide is at the very top, and the last time this data was updated from the state was on March 13th. Well, that's right about when the COVID cases ramped up, right? So it's highly suspicious that we haven't had any further EVALI cases since COVID-19 started. So I have to wonder if there was or is some confusion over EVALI and COVID-19, especially since the symptomology is very similar. And they also have very similar chest x-rays with a ground glass appearance. So it really may be very hard to differentiate what is EVALI and what is COVID-19. And really the only distinguishing factors are the fact that we might have to get from the patient history if they vaped within the last 90 days, and then of course a positive COVID-19 test. So to start wrapping things up here, while we are all probably sick of hearing about tobacco after all of these years, we have to realize that tobacco isn't a problem that's going away, especially here in Indiana. It is still the most preventable cause of death, disease, and even disability in our society today. We're focused on the 200,000 Americans that have died from COVID-19, and rightfully so. However, remember that more than twice that, 480,000 Americans die every year from tobacco. So we just want to reiterate that quitting tobacco is linked to decreased symptoms of depression, anxiety, and stress, and also increased long-term abstinence of substances of abuse by 25%. And despite tobacco's heavy disease burden, tobacco treatment really has not been routinely integrated into mental health and addiction treatment. So we still have a lot of work remaining in this fight against tobacco. So I'd like to ask you, what is your organization doing about tobacco use among your patient population? And what is it that you think you can do to improve this situation? So for those of you ready to answer that call to action, but not quite sure what to do, there is help available. Rethink Tobacco Indiana is a grant-funded initiative working with partners across the state. We provide technical assistance, policy development, education, specialized training, and all kinds of resources, and that's all free of charge. The one thing that we do that is not free is we do offer the tobacco treatment specialist training. Kayla and I are both tobacco treatment specialists. We've both been trained and certified by the University of Massachusetts to provide their accredited tobacco treatment specialist curriculum here in Indiana. Our next tobacco treatment specialist training is launching in October. We have stuff on our website where you can get more information about that training if anyone's interested as well. And unfortunately, we do have to charge for that TTS training, but we only charge what it costs us to put that training on. We don't make any revenue off of that. So with that, I'd like to open it up and see what questions you have, and I think I'll throw it back to Blake at this point to take us through that.
Thank you, Debbie. At this point, I believe, Sunny, are there any particular questions that were put in Slack?
You know, we do not have any questions, but had an excellent comment from Community Health Network's Priscilla Engel on Kayla's presentation. Priscilla writes, my patients love the text-based contact from Tobacco Personal Quick Coach. So great plug there for the program. Debbie, I wonder if we could re-invite you to ask your last question regarding the additional projects and or areas of additional programming that you had wanted to evaluate or survey from the attendees.
Sure. Do you want me to show my screen again?
I think verbal would be fine.
Okay. So we're just asking you, what do you think you can do in your organization or your setting to increase the chance that somebody would think about quitting smoking, and what could you do to help support them? And feel free to, do you want them to type that into the chat?
That would be great. Yes, we have a few folks that have already responded. Tasha Brown from Indiana University mentions that the IU School of Medicine is offering a teen vaping echo sponsored by the State Health Department. And then Mary Russell is submitting a question. How long to recover after smoking?
I'm sorry, Sunny, can you say that again? You cut out just for a second there.
Absolutely. Mary Russell asks, how long does it take a person's lungs to recover after they've quit smoking?
Well, that really depends, first of all, how long they've smoked, how much they've smoked, what type of irreversible damage has already been done to the lungs. But we do know that the health benefits can be seen in as little as 12 hours. For instance, 12 hours after somebody quits. One of the things that's ingested as part of the tobacco smoke is carbon monoxide. So by just quitting for 12 hours or less, their carbon monoxide level returns to normal. And one of the things that happens with carbon monoxide is it takes the place of oxygen in the body. So in just 12 hours, the carbon monoxide level drops to normal and the oxygen level increases to normal. We also know that the chance of heart attack decreases in 24 hours. And then, of course, the chances of cancer, as Kayla described in her presentation, happen for long periods of time. So the longer somebody can quit, the better, the less likely they are to get cancer. So I hope that helps answer your question.
Excellent. Thank you for those insights, Debbie. We encourage all attendees to either share additional programming and or volunteer any additional questions for our One question coming in is regarding policy. What additional public health policies should the state of Indiana be looking towards in supporting further tobacco cessation practices?
Kayla, you want to take this one since I took the last one?
Yeah, sure. In terms of policy, it would be really great if our Medicaid program reimbursed for those tobacco treatment specialists that provide tobacco counseling, and then maybe taking it a step further and increasing that reimbursement for those existing providers can be a really great step, as well as increasing the tobacco tax costs, and even for e-cigarette products as well. I will say that Indiana, so the federal law to buy tobacco products is 21 years old. That was effective December of 2019. And Indiana, they did pass our very own state law that's effective July 1 to really close any gaps. So we did fortunately do that.
One thing I'll add to that too is that, yeah, I'll add that what we can do on a state level too is to restrict the sales of flavored tobacco products, which would be huge in initiation of youth tobacco use. We find that youth really are drawn to the flavored products. So even the menthol and the mint, not just the fruit flavored, but even those products as well. So as a state, that is something we could do too, or local as well. But Kayla, I think you did a great job answering that.
Great policy feedback, ladies. Thank you. Elise Elder with FSSA comments that in the FSSA annual opiate treatment program reviews, we encourage staff to do all possible programs to help patients quit. They have taken down your information and will pass along the program opportunities. Further, Amanda Beretta with Eskenazi Health identifies, we use an incentive program that provides small monthly incentives and a larger incentive after a consecutive 365 days of being tobacco-free. You mentioned some incentive programs that end up with the client returning to using again after the incentives end. What do you think about the possible success of a longer-term incentive options such as this one, i.e. an extension of a year?
Kayla, go ahead.
So extending the incentive by a year, I think that, that would really only help to maintain that behavior over a long term. So I think it would only help, because, the further away that you are from the old behavior, the more that it becomes a part of you. People are identifying as being a non-tobacco user, a non-smoker. And so being further away from that versus if, you were only incentivized for maybe, let's say, 3 months, the likelihood of people typically returning to using tobacco products is going to be within that 6-month time frame versus if someone could achieve a year of abstinence, the likelihood of returning back to that would be lower. So yeah, that sounds like it would be a great plan.
Certainly accounts for even longer term behavioral change. Well, Kayla, Debbie, thank you both so much for being our speakers today. It's a ton of information shared. For Kayla and Debbie's handouts, you can connect on the GoToWebinar platform and simply select their presentations for download. Ladies, again, thank you so much for your insight and excellent information.
Yeah, thank you.
Thanks, everyone.
We again want to thank our symposium sponsor for this session, Anthem Blue Cross and Blue Shield, as our stakeholder sponsor. Earlier, we had a little bit of a technology difficulty in not being able to share the video. If you are interested in a 5-minute video from Anthem about their community impact and maximization of recovery communities and moving forward, you may find their video hosted at overdoselifeline.org under sponsors. Again, thank you, Anthem, for being our Session 4 stakeholder sponsor. Take care, everyone, and we'll reconvene at 3:30 for reentry best practices by CareSource and Jasper County Jail. Take care until then.